Trauma-Informed Care in Pediatric Practice presented by Dr. Sarah Hinshaw Fuselier, Dr. Melissa Middleton and Dr. Anna Kelley.
Dr. Hinshaw Fuselier is an LCSW PhD and assistant professor of psychiatry at the Tulane School of Medicine and the clinical director of the Tulane Early Childhood Collaborative, a regional program that provides infant and early childhood mental health consultation to pediatric primary care providers. Her interests primarily focus on supporting healthy relationship development in infancy and early childhood, directly with families and through workforce development with family-serving professionals. Clinically, she focuses on assessment and treatment of parent-child relationship problems, anxiety, trauma, and child custody issues for very young children. She's also engaged in policy efforts to address early childhood mental health awareness, literacy access, and integration across systems. Dr. Anna Kelley is a licensed clinical psychologist and an assistant professor in the Department of Psychiatry and Behavioral Sciences at Tulane University. She specializes in infant and early childhood mental health and is especially interested in the effects of early childhood adversity, as well as supporting young children and their caregivers develop healthy attachment relationships. Dr. Kelley emphasizes a strength-based perspective and promotes mindfulness and self-care as important elements in supporting caregivers with young children, as well as professionals working with young children. Dr. Kelley provides consultation to pediatric primary care providers through the Tulane Early Childhood Collaborative, TEC, to promote mental health in children birth to 6 years of age. Dr. Melissa Middleton is an assistant professor and licensed clinical psychologist within the Department of Psychiatry at Tulane University School of Medicine. Her clinical and research interests have predominantly focused on early childhood mental health, with a particular emphasis on parent-child relationships. She co-directs the Tulane Parenting Education Program, which is part of a statewide family resource network, provides assessments and interventions for children and families involved in the child welfare system. Dr. Middleton serves as a consulting psychologist to pediatric providers for young children and families in the pediatric care setting through the Tulane Early Childhood Collaborative. And with that, I will pass that over to you, ladies.
Thank you, Ashley, and good afternoon to everybody. Anna, Kelley, and I are here today to do this presentation. Unfortunately, our colleague, Melissa Middleton, will not be here today, but is very much a part of the work that we do. So I will just go ahead and say that we have no disclosures, and we are grateful to those entities that have provided philanthropic funding for the Tulane Early Childhood Collaborative since its inception in 2014. And with that, I will turn it over to you, Anna.
Hi, thank you everyone for being here. So I wanted to start off by just kind of introducing this and saying, why are we talking about trauma-informed care in the pediatric setting? And what we know really from decades of research is that the origin of lifelong health is in early childhood. And so what happens, especially in the early years, and I'm talking specifically about trauma and adversity, impacts our health both in the long term, and we know this from the ACEs studies, which I know we'll be talking a lot about throughout the course of this symposium. So in the long term, but also in the short term. And we're talking both about physical impact on health, but also, of course, mental health. So the American Academy of Pediatrics released this policy statement this year. So this is a very recent policy statement, and it's titled Trauma-Informed Care in Child Health Systems. And we're going to be talking about a lot of the points that they address in this statement. And one of the things that they say is that trauma-informed care is really a framework that we can use for pediatric practice to think about what we know about the evidence of toxic stress and what we also know about attachment and resilience, and to bring those together, so the knowledge of those two areas together, to really mitigate the effects of trauma, specifically in the pediatric setting. And as was mentioned briefly at the beginning, so a lot of the work we do is consultation in primary care settings. And what we've seen is that pediatricians are absolutely at the fore here of being able to do really important work in mitigating these effects of trauma. So we're really excited to be talking about this today. A few things I want to point out just right off the bat in terms of points that are really focused on here in this policy statement are that in order to do this work and to really implement these trauma-informed care, this framework of trauma-informed care, we want to focus on promoting and restoring resilience in children and adolescents. So even if children have experienced trauma, how can we get them back on track developmentally? How can we help really facilitate their resilience? And a lot of that has to do with partnering with the families to support the relationship between the children and their caregivers, because we know that that is a significant buffer to protect children from stressors and adversity. And the other thing, of course, that's really important is reducing secondary trauma among pediatric healthcare clinicians, because we hear all these stories and we need to protect ourselves too in order to really have a setting where we're providing good trauma-informed care. I just want to briefly mention that there's also a clinical report. Just for you all to know, we're going to be touching on some points referenced in that, but if you want to go deeper into it, then that is certainly available as well. Okay, so briefly, I want to just touch on what is trauma, and Dr. Middleton and I are actually giving another presentation tomorrow where we're going to get into this even deeper and talk specifically about what trauma looks like in young children and how to identify it. But what I'd like to cover today is just a broad overview of what trauma is. So based on the DSM-5, trauma is the exposure to actual or threatened death, serious injury, or sexual violence. An important piece to add is that it's not just the exposure for the child or adolescent, but if they see a caregiver being exposed to this, that also counts as trauma. So for example, if they're witnessing domestic violence between their caregivers, that absolutely counts as trauma. A few the most common traumas that I just want to touch on. Medical trauma is actually a significant trauma that we see. And the numbers are actually up to 80% of ill or injured children and their families have traumatic stress reactions after a life-threatening illness, injury, or procedure. So that's a really high number. Witnessing violence in the community or domestic violence is a trauma that we see commonly. Prolonged caregiving disruptions absolutely count as a traumatic experience. Parental mental illness, parental incarceration, and parental substance abuse, which are all ACEs. Those are all traumas. Animal attacks, maltreatment, and so both physical abuse and also sexual abuse. Natural disasters, and certainly here in Louisiana, we're always asking and screening for exposure to natural disasters, especially hurricanes, motor vehicle accidents, and also more recently, we're seeing pretty clearly in the research that racial trauma also has a significant impact on children and adolescents. And so we also want to be keeping that in mind. So I want to briefly go over the rates of trauma. And the majority of the work I do is working with children who've experienced trauma. And still, when I see these numbers, I'm always just really surprised and shocked at how high they are. So more than 2/3 of children in the United States report at least one traumatic event by the time they are 16 years of age. Specifically, in terms of witnessing community violence, the rates range from 39% to 85%. I know that's a very wide range, but even if we're just looking at the lowest number there, 39%, that's still significant. And exposure to sexual abuse is estimated to be 25 to 43% of children under the age of 18. And for girls, the numbers are higher. Now, when we look specifically at Louisiana, we know that we're 49th in overall child well-being compared to the other states in this country, 48th in family and community. And just a few specific numbers I want to point out. So for infants and toddlers in Louisiana, 27% are living in poverty, 47% are Black. And these are higher than the national averages. The reason we point some of these out is because both racial minority groups and children growing up in poverty count as high-risk groups for trauma. So especially when we're seeing these families in our pediatric settings, we need to really be thinking about carefully looking at and screening for trauma, which we're going to talk about in just a moment. I also want to mention that in Louisiana, we have the rate for infant and toddler maltreatment is 20%, and 10% of our infants and toddlers have experienced 2 or more ACEs. So just to give you all a picture of how really, this is showing up everywhere, and it's so important to be focusing on this. Okay, a few of the effects that we see when children have experienced trauma, of course, PTSD. And I want to just briefly mention, so there have been studies that have actually found when they've looked at PTSD symptoms in children growing up in inner cities in the United States, and then PTSD symptoms in children living in war zones in countries where there's active conflict, the rates are similar. So there's a lot of language in these studies around urban war zones for children growing up in the United States. So the rates of PTSD really are quite high for children in this country that we're serving. Then certainly depression can be an outcome of trauma. We see a lot of aggressive behavior and difficulty with peers. We see poor academic functioning and an increased involvement with the child welfare system and then the juvenile justice system. So, and overall, and these are all our ACE studies, but long-term health problems when children have experienced trauma. So overall, trauma is a risk factor for nearly all behavioral health and substance use disorders. Okay, this is a study we briefly wanted to mention. And what I think really stands out with this study is that this is an ACEs study, but a lot of our ACEs studies look at long-term health outcomes. This study actually looked at outcomes by the age of 5. So children who have 3 or more ACEs by the time they turn 5 years old are 2.5 times more likely to have physical health problems and developmental delays. And they're 8 times more likely to have mental health problems by the time they're 5 years old. So it's not like we're waiting until they're adults to see these effects. We're actually seeing them now. And so it's really important that we're intervening and creating these systems of care that are trauma informed.
Okay, so we're going to shift into talking about what trauma-informed care might look like. We want to just call attention to the fact that there are several organizations and entities that are thinking about and talking about trauma-informed care and what that looks like. And the good news is that there's a lot of overlap in the definitions, but we'll just go through a couple of them to give you a flavor for that. So the AAP talks about trauma-informed care as being an organizing principle for pediatric practice that improves the awareness of the spectrum of trauma-related symptoms, promotes an emotionally safe environment of care, and provides specific interventions to mitigate the effects of trauma exposure. The National Child Traumatic Stress Network, which is a really great resource, and their website is in our resources and is highly recommended if you're not familiar with it already. But they define trauma-informed care as medical care in which all parties involved assess, recognize, and respond to the effects of traumatic stress on children, caregivers, and healthcare providers. So Anna briefly mentioned this, and I want to call this out as well. I think we could spend an entire session talking about the impact of caring for patients with high levels of trauma on providers. We're not going to really delve into that a whole lot today, other than to say that that needs to be a piece of trauma-informed care, is to recognize secondary stress and to really focus on what healthcare providers need in order to provide this kind of care for patients and families. And then SAMHSA has laid out 4 key assumptions for trauma-informed care. So in SAMHSA's words, a program, organization, or system that is trauma-informed realizes the widespread impact of trauma, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So we're going to go through the realize, recognize, respond a little later on. And before we switch into some examples, we want to just look at what the core elements of a trauma-informed system look like as conceptualized by the AAP. So the first is providing a safe physical and emotional environment. So the space and the interactions that families experience are characterized by compassion, cultural humility, equity, and collaboration. And this is true for families and for employees. So in a trauma-informed system, non-clinical staff need to also be knowledgeable and responsive and supported in order to create this kind of safe environment for patients and families. There needs to be a leadership commitment to trauma-informed care, which includes things like regular review of policies and procedures, an allotment of resources to providing these kinds of services, and universal screening for patients and staff. So recognizing that staff may also be carrying a lot of trauma with them, and that may interface with the trauma that patients are bringing to the clinic. And so there really does need to be a comprehensive supportive system. Patient and family empowerment is another core element. So involving families and youth in the development of policies and procedures. I think this is a little bit newer, and I think that there is a lot across a lot of systems. There's a lot of talk right now about how to truly engage with families and allow them some leadership in the process to make systems feel safer and more responsive to their needs, and that we need to be paying special regard to cultural, historical, and gender issues when it comes to family empowerment. Another core element is that trauma-informed care is continuous throughout the healthcare system. And so Anna referenced earlier the guides from the AAP, and you can see I just have this graphic that gives you a flavor of the kind of information and materials that are available to you as you think about how to make your practice more trauma-informed. But we want to be thinking about primary, secondary, and tertiary prevention strategies, and what does trauma-informed care look like there. And then finally, recruitment and training of a trauma-informed and compassionate workforce. We need to think about things like hiring practices and how this plays into who is hired and how people are hired. As I mentioned earlier, all staff, administrators, clinicians, clinical and non-clinical staff need to be aware, need to be trained on within their role what is a trauma-informed response. Advocating for the use of continuous quality improvement, so kind of an iterative approach to getting feedback and making improvements, seeing what works in your practice, what isn't working, how can you tweak the system that you're trying to implement so that it is working better. And again, commenting on the secondary traumatic stress. So providing training so people are aware of it, but also providing kind of the supervision and support that folks need. And then lastly, coordination of care across family serving systems in the community. So there needs to be collaborative, interdisciplinary relationship between community agencies that coordinate care for children and adolescents. So thinking outside of your own silo of practice and thinking about how do you coordinate with the other places where children are found, schools, mental health, home visiting, child welfare, early intervention, juvenile justice system. And another topic we could probably spend a lot of time on, and thanks to Laura Alderman for calling out the need for some advocacy and funding around early childhood in particular, but to provide trauma-informed care for all children and adolescents and families, we do need a commitment from federal and state government, from hospital systems, from insurers. And this is a comment actually taken from the AAP policy statement, but so that resources and policy are aligned with the elements of a trauma-informed system. That's mostly all we'll say about that today, although I will say that if you have interest in advocating for these things, I would invite you to please reach out to me. Okay, I'm going to turn back to you, Anna.
Okay, So, so this is the question we often get. Well, what can pediatricians actually do, right, on a day-to-day basis in your clinic seeing children? And I want to start off by saying that pediatricians, and I touched on this before, but pediatricians are absolutely vital in identifying children exposed to trauma and then supporting them in accessing the appropriate services. A big piece of this is because that's where the children are. Children go to their pediatric visits, right? Children have to attend their wellness checks. They have to do that in order to go to school. And so this is really the first place often that they're seen. And also they're, because they have to come to frequent visits, there's a really nice opportunity to build a relationship with families and children over time. By the time that children and adolescents come to our community mental health clinics, often they now have an entrenched pattern of trauma or relationship difficulties, and it takes much more effort and time to get them back on track developmentally. So we can do a lot specifically in the pediatric setting. So the first thing is promoting development, and specifically I want to focus on promoting relationship development. So really focusing on, I mentioned this earlier, but the relationship between the child and their caregiver is a significant buffer. So even if the child is experiencing trauma, even if they're growing up in a community where there's a lot of violence, if they have a caregiver that they feel safe with, the chances that they're going to develop symptoms and struggle are actually much lower. So we really want to enforce that. And that's one big thing that pediatricians can point out and talk to caregivers about. Yeah, next slide, thanks. The next thing that's really important, and honestly, I find maybe the most important thing, or at least one of the most important things, is screening. We catch so many children who have been exposed to trauma by screening. And I'm going to give some examples in just a moment of what screeners you can use and what we're looking for. But one of the things is that it really helps to identify when a higher level of care is needed. I want to point out too that this year actually, there's now, as of this year, there's reimbursement available for developmental and autism screening, and also for perinatal depression screening in Louisiana. And then, of course, if there is a screener that's positive, making sure that pediatricians are following up, doing additional screening if necessary, and of course, regularly checking in. And then referring as needed. So I get the question a lot, well, if we do these screeners and if we find out that children have extensive trauma, then what? Like, we don't know where to send them. And so that's a very valid question. Like I said, it comes up a lot. At the end of our presentation, we have several resources, and we're happy to share those with you as well, of where to look for good services that you can refer children and families to in Louisiana. So we'll definitely share some of those with you. The other piece is monitoring really closely during subsequent visits. So if there is a positive screener and you know that the child that you're working with has experienced trauma, making sure that on every visit you're following up, you're screening again to see if the symptoms have changed at all. And the AEP does state that for children that have special healthcare needs, and certainly mental health counts as that they need a lot more time and close follow-up. Okay. All right, so this is one of the screeners that we use. And so we wanted to go over it and share this with you all. So this is the SEEK, which is the Safe Environment for Every Kid. We recommend doing this with every family that comes in. It's clinically valid for child and adolescent populations. The caregiver fills it out, and they can do that in the waiting room. It requires very little time, and it is available in multiple languages, and it's available free of cost. So even just one positive answer on the SEEK does require follow-up. And I know this is pretty small, but I want to show you here. So it goes into questions about parental mental health, which we know is an ACE. So do you wish you had more help? Do you feel under extreme stress? Have you felt down, depressed, or hopeless? It does ask questions about domestic violence. Have you been afraid of your partner? About parental substance use? And then it goes into specific questions about trauma. And we have actually added these in our consultation program, because what we found is that if you directly ask, has your child experienced trauma? We were getting a lot of responses that were no. But then if you go and specifically say, has your child been in a car accident? Have they been separated from you for a prolonged time? Have they seen someone get hurt? Then we were starting to get a lot more yeses. And our understanding of this is that trauma is such a broad term, and a lot of families don't know exactly what we're referring to when we ask about trauma. So really asking specifically is very important. We've chosen the SEEK as the questionnaire that the screener that we use, because there have been studies that have found that when it's used in resident clinics, there is an outcome of decreased corporal punishment in families, and better care was documented overall. So providers are asking more about depression, about violence, about substance abuse, and feeling more confident. And we have found that this is really helpful, and we catch a lot of children by administering the screening. Next one, yeah. We also want to mention there are, of course, other screeners, and we want to just give you a few different options. So the PEARLS is an additional screener. That is a specific ACEs screener for the pediatric setting. It's available at the website here, ACEs Aware, and they have a lot of other topics and resources as well that may be helpful for you. So you can certainly use that as well if you prefer.
Okay, so prior to the break, there was some discussion or some beginning discussion around barriers to using consultation. And we conceive of consultation as part of a spectrum of integrated behavioral health care. And so Anna will talk a little bit more soon about our consultation program. And you got to hear earlier from Juliana Finelli about the perinatal consultation program. But when we're talking about trauma-informed care, we're really talking about integrating to some degree behavioral health care. Certainly by addressing trauma and mental health symptoms in primary care, we're diving into behavioral health. And then we go kind of all the way over to the other end of the continuum of having integrated teams where you might have a behavioral health care provider on staff or even a team on staff. So that is, it feels very logical, and it feels like we're getting to a point in time where we are recognizing that we really can't tease apart physical and mental health, but there are a lot of barriers still. So one of the things that that there is documentation of, and that we certainly see anecdotally, is that there is often not enough training in behavioral health and trauma-informed care for primary care healthcare providers. So this kind of translates into not feeling very confident or very comfortable in talking about screening results with patients, not knowing a lot about what to say or do, not knowing a lot about what the referral sources are. And certainly today you've heard about a lot of different avenues where many groups are trying to make referral sources more available to you. And again, we'll have a lot of those listed on our resources slide. So we'll come back around to that one. We did hear about this earlier. Lack of time is a real concern. There are a lot of things that you're required to do in a well check, and clinic can be very busy, and it can be hard to go into this area, especially if you don't feel like you have the tools or the support or the knowledge to do it. And that kind of gets into the lack of institutional support. So it's really important to be in a practice, in a setting, in an institution where you have the tools that you need and the support that you need to provide this kind of care. I kind of touched on this a minute ago, but there is a perception that mental health is not part of primary care. I do think that that's getting better. But, I think that we have to make this more accessible and help people understand how truly integrated they are, especially when we're talking about children. It's really hard to kind of, break children apart into these different entities as if their lives are not all intertwined between their physical and mental health. And you can even see that with the ACEs study that Anna talked about earlier. Funding is a big issue. We've touched on that. Laura Alderman touched on that. We just don't have enough funding for behavioral health support services. And there are a lot of people working on that also. But again, the more that that you all can help with what you're seeing and what you're seeing in terms of gaps and what you're seeing in terms of supports and services that are available that are helpful, and communicating that out and up will help those of us who kind of work at it from a systems level. Same for referral services. And then a lack of established protocols. So another thing that we hear about is concern about being able to meet the behavioral health needs of all patients. What do I do if somebody screens positive? I might not have time. I might not know where to send them. Is it really my job? So a suggestion that we have for you is to collect data about referrals. If you can follow along with referrals that you're making or trying to make and get some documentation about the gaps in services that you're seeing, it may lead to a change in your practice in terms of maybe hiring a behavioral health provider or writing a grant to get support for that kind of thing, but also, again, passing it to folks who work in systems and advocate in for government funding. And then finally, I want to talk for a minute about underserved communities and the additional barriers that healthcare providers serving these communities face. Often you all are facing large caseloads, probably overworked and underfunded. A lot of the things that we are recommending that people do may not be billable, or you may not know how to bill for them. And you may not have space. Maybe you get a grant, maybe you have the funding and commitment to bring in behavioral health care providers, but you're already possibly working in crowded space. So how do you do all those things? So to be successful in really integrating behavioral and medical care does require time, it does require training, and it does require funding. So basically a trauma-informed approach ensures that all staff have the institutional support and the knowledge and the skills that they need to support families with trauma exposure. So tying these together, what we want to do now is just look with you at a few examples of trauma-informed care in pediatric practice. There are many, many ways to do this. And so our goal today is to not try to be comprehensive or tell you this is what you should do, but just to get you kind of thinking about what are some different ways that practices and people are thinking about this, and what are some things we might want to try. So the first example that we're going to give you is out of New Mexico. This is the University of New Mexico's Young Child Health Center. This is a community-based, family-oriented, patient-centered medical home. You can see their population service area. There are high rates of poverty, community violence, domestic violence, young parenthood, single parenthood, unemployment, et cetera. They have a small behavioral health team on staff, a part-time psychiatrist, a part-time psychologist, and then they have some social workers and case managers, and then they of course have trainees. They engaged in an implementation study with a clinic-wide effort to have a trauma-informed procedure, including screening, identifying, and discussing traumatic stressors, and providing support to all the families who attended well visits. They chose to use the SEEK. Anna just talked about the SEEK. So they chose to use the SEEK plus some surveillance questions, and they engaged in the PDSA model. So we talked about CQI earlier. So this is the Plan, Do, Study, Act. It's sort of an iterative approach to seeing what's working. So getting feedback from a range of folks who are involved with the implementation to see what works and to tweak it to make it continue to work better. Their goal was to create a sustainable, non-cumbersome process for identifying children and families with traumatic stress, and to connect those families to appropriate interventions if the families so desired. So they engaged in routine screening. And some benefits of routine screening are that it helps create a clinic culture that encourages discussion of trauma and stress and family needs. It has the added benefit of increasing provider awareness about patient needs, and it emphasizes the importance of addressing trauma. It also increases provider comfort with talking to patients about trauma. It obviously is going to do a better job of identifying families in need of behavioral health support to do routine screening, universal screening, as opposed to screening when you have a hunch that maybe something's going on, or when the family comes in complaining about a behavioral health need. So it's a more equitable approach as well. And then it can really improve the patient-provider relationship as you begin to screen more and figure out more about what families' needs are. The quality of care improves, families feel cared for, you develop this relationship, both with families and with other healthcare providers. So again, reaching outside of your silo and coordinating with other child serving entities so that there's a comprehensive system that's supporting children who have been traumatized. Having a screening tool helps providers and families begin these conversations that can be difficult to have, and topics around, what are the effects of trauma, what are the behavioral health needs of families, and what resources are available to families. So what they found in their study between 2015 and 2018, I'll just point out on the graph here, you can see that this little small dotted line is the number of seeks that they administered. So that shot up. So rather than identifying people they thought maybe needed a screener, they just screened everybody. And so they were clearly doing a lot more screeners. And if you look at this sort of broken line here, you can see that they began to identify families who were in need a lot better. And then this solid line here is their behavioral health referrals. And so those increased as well. And by 2018, at the end of their study, 85% of the families they referred to behavioral health services attended their first appointment, which was an increase from 57% back in 2011 before they started this trauma-informed care approach. And Anna is going to talk with you all about consultation and how that supports trauma-informed care.
Yeah, so we wanted to give you a specific example about what consultation can look like. This is actually our program, the Tulane Early Childhood Collaborative. And I'm going to very briefly, give you kind of an overview of what we do, and then I'm going to present a single case that we did. So the reason we developed this program was really to address the gap that we saw between the needs we were seeing in terms of young children's mental health and the actual access to appropriate services. We often have long wait lists. And so the thought was, well, if we can get in the pediatric setting, we may be able to do some short-term support and bridge that gap. So what we do is we provide consultation to pediatric care providers in the New Orleans area and in the Baton Rouge area as well. And our goal is really to promote mental health in children aged 0 to 6. We do that in a variety of ways. So Sarah, if you could actually click through, there'll be some things that pop up. Yeah, so we have some web-based resources, and we will share our website with you all at the end. There's a lot of different handouts there that pediatricians can use. We also do didactics and training. You want to just keep clicking through? Yeah, perfect. We do provide consultation via phone or email. And then we're also on site. So when we're on site at clinics, that's the majority of the consultations that we do. We do both indirect, so a provider can come to us and ask us a question, and then they'll go back into the room and follow up themselves, or they can directly ask us to go in, and then we can go in and do a consultation with the family. And then sometimes we do brief intervention if needed, and we certainly can do referrals and follow up. So the case that I'd like to share with you all, this occurred in a pediatric clinic where we had been working for several years, and so we had a close relationship with the providers, and so this happened during a 12-month check, and this little girl had come to her appointment with mom, with her biological mother, and the pediatrician noted during the appointment that mom several times referred to her baby as mean. And we had done some work already around the importance of healthy relationships, and so the pediatrician said, well, something feels off to me about that. Could we go in together, and could you do a consult and see if there's something else going on? So that's a great consult question. So we went in together and we screened, and we used the SEEK. And one of the things that came up was that mom said that she had been afraid of her partner in the past year. And so there was a history of domestic violence. And also she said that she had been experiencing some of her own mental health concerns. And when we asked her more about it, and one of the strategies that across the board when we're doing trauma-informed care is recommended is always to ask families permission to ask them more. So when you have the seek, and anything's positive, that's a great way to start to kind of get in the door with asking about trauma. You want to always say, do I have your permission to ask about your responses on the seek? And it has never happened to me that a family has said no. And so mom said yes. And then we said, well, can you tell me more about what you said here, that you've been afraid of your partner? Can you tell me more? That's another strategy that we recommend to providers, just saying, can you tell me more about this? Very open-ended, and you already have that, you already put in the door because the parent has said yes to that on the questionnaire. So mom did share that she had this history of domestic violence with the father of the baby. And when we were in the room, what we noticed is mom actually had some pretty strong fear reactions to the 12-month-old. So her little girl was starting to pick up things and kind of throwing them a little bit. And whenever she would do that, mom would actually flinch. And we talked about this, especially in light of the history of domestic violence. And mom did say that that she was reminded of the father of the child. And so we were able to talk about that. Of note, baby was absolutely developmentally on target. And mom had said that she just started feeling like she was becoming mean. So this was a very new perception that mom had of her baby. We can go on to the next slide, Sarah. Thank you. So what did we do? So in the consultation, we provided psychoeducation for mom about the importance of her own mental health. She had actually stopped taking her medication because when she got pregnant and then was breastfeeding, and as you probably heard in the previous presentation about LAMP, this is a common fear that some parents have, and she unfortunately did not have good support in that. So we strongly encouraged her to reconnect with her provider and to get her own support. And we talked about domestic violence and how that, and her exposure to domestic violence and how that may be affecting her perception of her baby. And we just provided guidance around the throwing and picking things up, and that was really normal and healthy, actually, that her baby was doing this. And helping her see that was a perception she was having of her baby, but not actually rooted in real intention that baby was trying to hurt her. We did make a referral to T-Bears, which is an in-home visiting program, and mom agreed to that. We also got her connected to a coordinator for housing because she was still connected to the father of the baby because of financial reasons. And so we wanted to support her in getting her own housing. I'm going to briefly mention this room. This is one of our things we recommend to all pediatricians to provide to children. It's an app, and you can put in baby's date of birth. It goes up to 6 years. And every day it gives the parent or caregiver an activity that they can do with the child to help promote different areas of the child's development. And parents love this. So we always recommend this. And then we recommended strongly that the pediatrician follow up very closely and screen on every visit, and actually have the child and mom come back before the next routine visit just to check in and see how they were doing. I was able to join for a follow-up that happened 6 months later, and they were doing really well. And mom was connected to all these services and no longer was perceiving baby as being mean or trying to hurt her. The reason we wanted to bring up this example specifically is because this is such a good example of catching this really early on before the relationship can become problematic. I believe that if there had not been intervention here, that mom would have continued to perceive baby as mean. And then at some point, the child starts taking that perception on and believing it about themselves. And we start seeing behavior concerns. And then we just have this kind of negative feedback loop that continues. But if we can get it really early on and provide support, we're able to get baby and mom, in this case, back on track developmentally. And they actually ended up having a really healthy relationship. Okay.
All right, so I know we're coming close to time, and as we begin to kind of wrap up, Are y'all hearing an echo? Is that just me? Okay, great. As we begin to wrap up, I want to kind of pull the lens back a little bit again. And if you remember in the beginning, we talked about some definitions of trauma-informed care, and the key principles that SAMHSA laid out include realize, recognize, and respond, which has also been picked up by the AAP. And the example here that we're going to talk about is Maine Health ACEs program. And so this is a healthcare system that decided to become trauma informed, and they've developed a whole set of materials and supports for practices that want to become trauma informed. So we're going to use that as another example as we also kind of think about what are the principles that you want to think about as you decide how you might want to increase the trauma informed care that you provide. So the goal of the Maine Health ACEs program was to prevent, identify, and treat ACEs. And what they offer pediatric practice is assistance in education for staff, integration with behavioral health care, implementation of ACEs screening and trauma-informed care, optimizing their use of their electronic medical records and patient registries. So the AAP policy statement says to realize the effect of traumatic stress, especially during early childhood, on lifelong health. So what Maine Health then implements from there is providing educational opportunities and resources for all members of the care team. And again, I want to really talk about this and think about this. The folks who are in the front of the office are very important to the experience that patients have, and really everybody who's involved before and after they see the pediatrician for the visit, right? So you've got care coordinators, you've got nurses, you've got front desk staff, you've got billing people perhaps, and there are a lot of perceptions and things that they see, all these other staff, that pediatricians often tell us they don't see. And so they can be really important members of your team, as far as giving you information, helping you support families, and making that environment safe for families. And the second principle is to recognize. So the AAP policy statement says to recognize trauma-related signs and symptoms through screening and surveillance. So we've talked a lot about screening. We started off the day with Laura Thornton talking about screening. You should probably by now know that there are a lot of screeners available and that these help identify symptoms. They help guide treatment options. Another thing that Maine Health advocates is to use your electronic medical record effectively so that within the system, wherever things are happening or screening is occurring, providers are aware of the results of those things. Anna touched a little bit on this earlier about trauma-informed interviewing when addressing positive screens, asking permission, being empathic, being non-judgmental with families about what's happening. Do you mind if I ask more about this? It's a simple, quick statement, and it goes a long way in building rapport and solidifying relationships with patient families. And then assessing safety, severity, risk, and resilience factors. And then thirdly, respond. So the AAP policy statement says respond with practice management, policies, and procedures to mitigate post-trauma stress and avoid re-traumatization. We've talked a little bit about building resiliency through the day. Laura talked about that, Alderman, when she talked about ACEs, and providing hope is really an important aspect of trauma-informed care. So making sure for yourself and for families that you're identifying and recognizing strengths that they have as families, strengths that the child has, supportive systems, what is available in the community that is of support to them, and encouraging positive parenting strategies. This goes with every well-child visit. You're promoting positive parenting, you're promoting development, using follow-up visits to monitor progress. Don't necessarily wait till the next well-child visit. If something's going on, it's important to use those screeners to track the progress and see if the symptoms are reducing. Referrals to behavioral health clinicians who can provide evidence-based practices. Had a presentation on that this morning. Also, and there are a lot of resources that are increasing around the state, a big effort to make more services available. I know you got that information earlier. It's also on our resources, but the link to the Center for Evidence to Practice. And then, back to the idea of CQI, getting feedback and ideas to help improve the process as you go. The first thing you try might not be the best thing. The important thing is to begin somewhere and to try to implement some form of trauma-informed care or some aspect of it, and then continue to grow. This is just another resource for you. You can get this online at mainehealth.org/ACEs. They have a toolkit. They have, we've talked about different screening tools, but they have a list of screening tools that they use and recommend. But you can also see they have these things like these workflows here that are shown. So a lot of really practical information to help you get started. And then just a moment to reiterate some of the sustainability strategies that we have talked about, but characteristics of trauma-informed care that will really go a long way towards supporting that implementation are having highly trained teams, having standardized workflows, using this trauma-informed approach, maximizing your treatment team, integrating with behavioral health, or at least reaching out and knowing your community providers, using your EMR and your patient registries effectively, creating a resilient culture, a culture that champions that resiliency in staff and in families, and then really engaging with families. And I know we're about out of time, but Anna is going to quickly run you through some resources.
Yeah, I'm aware of our time. So I think what I'll just mainly say is, I think everyone has access to the slides, and if not, we're certainly happy to make sure you get these resources. These are just a few strategies that have been found to be helpful. So let's just go through the slides so you just show what we have. Yeah, so these are different ways to approach. And then here are a list of local resources. We have a great list on our website for community resources, different things that parents might need. So I'll just point you in this direction. And you can see there's a lot of different resources here. So we'll make sure you all get those. And thank you so much.
Scan the QR code on the screen or go directly to the link to complete the evaluation and claim continuing education credits after viewing all of the sessions. Thank you for viewing this session. Please reach out with any questions or if you have any additional needs.